Welcome you all to our session tonight. My name is Ruth Slack, and I'm a professor at the University of Ottawa and also the director of the Brain and Mind Research Institute. So on behalf of all of us, the researchers and our administration team, thank you so much for coming. De la part de notre chercheur et notre équipe, je vous souhaite la bienvenue et je veux remercier pour votre participation. So this week, as you all may know, is Brain Health Awareness Week. And the goal of this week is actually to increase awareness of brain health and also to tell you about the latest research discoveries at the Brain and Mind Research Institute, which is a leader in neuroscience research and also, and also research in developing new treatments for brain and mind related disorders. So tonight's session is focused on can the brain repair itself after stroke? And that's a subject that's very active here, a lot of active research going on here at the Brain and Mind Research Institute. And the University of Ottawa and the Brain and Mind Institute is actually an international leader in stroke research. And I'll just give you a couple examples. So the Canadian Stroke Network was actually founded here at the University of Ottawa by Dr. Tony Hakim. And this has led to major changes in stroke care. We also here at the University of Ottawa have founded the Canadian Partnership for Stroke Recovery, which is bringing researchers from across the country together to focus on developing new treatments for stroke recovery. And also at the Brain and Mind, we have a major pillar. One of our major pillars is on stroke, and we bring together clinicians as well as basic researchers and also patient groups to focus on better treatments for stroke. So it's a real pleasure today to introduce our first speaker, Dr. Dylan Blaquier, who is a stroke neurologist and a clinician investigator and professor and researcher at the University of Ottawa Brain and Mind Research Institute. And he's going to tell you about how to recognize the signs of stroke and also the new treatments over the last few years for stroke. So thank you so much.
Thank you. So while we're getting this set up, thank you very much, all of you, for coming. I'm Dylan Blaquier. I'm a stroke neurologist at the Ottawa Hospital. And it's my very much pleasure to be here today. Just to kind of frame the discussion of what it is that we're here to discuss, which is the recovery from stroke. In order to understand how we recover from stroke and what our research is trying to target, though, one thing we should all make sure we're aware of is what a stroke actually is and how we're actually trying to treat strokes here in 2019. So with your permission, I'd like to tell you a little bit about where the state of the field is in that in about 10-15 minutes or less. So just my disclosures, and the one that's kind of relevance specifically to this today is that I'm on some of the writing groups for the Heart and Stroke Foundation of Canada's best practice guidelines. So, and this is actually something that many of us here in Ottawa are involved in terms of helping to write the guidelines for care, acute and recovery in stroke. So what I'd like to do over the next little bit is to talk about what a stroke actually is and frame that problem as we talk about how we recover for people who've experienced strokes. I'd like to talk a bit about how we prevent strokes and how we treat strokes when they do happen. And I want to review the signs and symptoms of stroke like we talked about so that you know what to do if you're having one. And this is probably a situation that's been very near and dear to some of you, either through your own personal experience or those of you with families who've had this. And later on this evening, we're going to have a chance to answer some questions that you have about this field as well, too. So just a few sobering things to think about is that stroke, when we talk about it in Canada, is a really important health problem. It's still the second to third most important cause of death in Canada. It is trending downward, but it is still one of the most important reasons why people die in Canada. It's the #1 cause of disability in adults, and that's a really key point to this. And that in fact, most of the time, the problem is not that stroke kills you, but it leaves you disabled afterward. And that's one of the key problems as we try to recover from this. We think in Canada there are about 50,000 new strokes per year. About 15,000 people will die of stroke per year, but that leaves about 350,000 people at any one time in our country who are experiencing the consequences of stroke. And that's a lot of recovery that we have to try to promote. And those can be people who suffer from things such as fatigue or subtle cognitive differences, to people who are experiencing very severe motor function or speech disturbances that are making it very difficult for them to participate in their daily lives. What stroke actually looks like is this. And so we can have varying degrees of stroke size. This is the human brain, both an MRI and a CT scan. This is not the same person, but this just goes to show you that strokes don't necessarily all cause the same amount of damage at any one time. Most of the time what we're dealing with is something called ischemic stroke, and that's what this looks like on a scan. The crux of ischemic stroke, this is one slide of neuropathology compressed down into about 2 seconds of me explaining this, so you actually might know more than some people who've gone to med school at some point with this bit. But basically the idea is that a blockage happens in the brain. So a clot either forms within one of the blood vessels of the brain or travels to one of the blood vessels from somewhere else. And it occludes an area of the brain tissue, blocks it off, keeps blood from getting past it. There's an area of the brain that as soon as that happens, there's already no flow left in it. And that brain is probably going to die regardless of what we do. We call that the core. But there's an area around that core called the penumbra. And this is one of the key things that we look at in stroke research. The penumbra is an area where there's not enough blood getting there to be able to sustain the function of those cells that are there. But if you open up the vessel quickly enough, if you restore the blood flow to that penumbra, then that tissue is salvageable. You're going to be able to bring it back. And so most of what we're looking at in terms of stroke recovery at this point in the acute phase is trying to undo those occlusions so that we can restore the blood flow as quickly as possible and salvage that tissue. Because eventually, if you don't do that, that penumbra is going to be lost to you and it's all going to become core, and that's going to leave you with a large stroke at the end. You may hear the term mini stroke a lot. You may hear the term TIA an awful lot as well too. And this is a term that we actually don't like to use an awful lot. TIA, mini strokes, they kind of don't really play on the significance of it that much. It sounds like it's not that big a deal. But this is something that is one of our key focuses of clinical research in the Ottawa Hospital, is trying to define what a TIA is. For those of you who don't know, it's basically a stroke that gets better. So somebody who has weakness or speech disturbance, some symptom of a stroke that goes away after a period of time. And we think that comes from a blockage in the brain that dissolves or breaks up before any permanent damage is done. The important key for us is that this is a really important warning sign that a larger, more permanent stroke could be coming. And so that's a key feature in all of this as well. Ischemic strokes make up about 85% of all of the strokes. So far and away when we talk about strokes, we're talking about blockages. But some people have what are called hemorrhagic strokes as well too. And this is where there's actually a bursting of a blood vessel within the brain. And this is a very different mechanism, but it can lead to many of the same problems. That tissue is vulnerable to damage from the expanding blood clot within the brain. It can cause shift of contents. It can cause major problems that can lead to almost as indistinguishable a problem as an ischemic stroke can be. So this is another key area of research as well too. When that tissue is blocked off, when there's a blockage that occurs, for every 10 minutes that goes by, it's equivalent to losing 19 million nerve cells. So if you think about it, this is very, very time dependent. And somebody's actually estimated it out. For every 10 minutes that a stroke is happening, that's the equivalent of your brain getting 7 months older, in fact, in terms of cognitive areas that are lost. And so even if we're able to unblock that tissue fairly quickly, there's still damage done to it. And we're only now starting to understand that even if things like weakness, speech disturbance, the obvious signs of stroke, even if they're fixed, there oftentimes are sequelae of this left afterward that are just as important and just as potentially disabling for people as well too. So when we talk about what causes strokes, we tend to break this up into things that you can change and things that you can't change. The older you are, the more likely you are to have a stroke. If there's a strong family history of stroke, then there's an equally higher chance that you might have some yourself. There's probably not much you can do about that. Likewise, if you had one stroke before, the likelihood of you having another stroke might be a little bit higher. But there's things that you can change, especially things like blood pressure, which we know now through some of the research that was done through groups like the Canadian Stroke Network here, is that high blood pressure is very, very importantly tied to the risk of developing stroke afterward. In addition, things like diabetes, high cholesterol, alcohol and drug use, and cigarette smoking, very important in terms of risk factors for stroke. Atrial fibrillation, if you have a specific sort of irregular heartbeat, that can also cause a blood clot to form within the heart and then travel up to the brain. So atrial fibrillation is an important cause of stroke as well. In terms of things that cause strokes, we tend to break things down into broad categories. So sometimes people have strokes because of blockages in the large vessels, like the carotid arteries in the neck. So if you happen to know anyone who's been told they have a blockage in their neck, that might be what they're talking about. And that can cause a blood clot to break off, travel up to the brain, and lead to the symptoms that we see. Those clots can also come from the heart. Like I said, if somebody has atrial fibrillation or some other cause within the heart where a blood clot might form, the brain is the largest place where blood happens to go from the heart. And so blood clots from the heart, it's very easy for them to travel there and cause major damage. We also know there are other causes, and sometimes we aren't actually able to identify a specific cause, even with an appropriate workup. So one of the things we're trying to do in our research is determine if we can't identify why it is that a person has a stroke, what is their risk going forward. When somebody comes to us with a stroke, though, there's specific things we want to know about. We want to talk about those risk factors, like I said. We want to look at the actual imaging of their vessels themselves. So do they happen to have blockages in their neck? Do they happen to have problems in their heart that could lead them to form clots within there? What's their blood pressure like, and are they controlling it very well? And even if it's good today, does that mean it's good all the time? How well is it being measured and managed? And then sometimes there's other causes as well that we have to look at in very individualized cases. If there's genetic potential components, if there's a strong family history, if a person has another underlying medical condition such as a cancer that may make them more likely to have a stroke, then we sometimes have to investigate for those things as well. That's only one part of it in terms of trying to prevent strokes from happening or trying to understand why they happen and preventing them from further. But if somebody does have a stroke, there's a whole continuum of care that we try to set up for it. It begins with trying to avoid them from having a stroke in the first place, but if it does happen, the next thing we depend upon is people being able to recognize the signs and symptoms of stroke. I told you earlier that every 10 minutes goes by, there's a significant amount of damage that's done. So it stands to reason if somebody's having a stroke, the faster they get to us, the more we're potentially going to be able to save. So having people know what the signs and symptoms of stroke are is very key to that. Afterwards, we have to have systems where people can get to the hospital very quickly. And once they get there, to be able to offer therapies that could potentially unblock those blocked up arteries. Even after that, once they get into the hospital itself, being able to treat them on a place where there's that dedicated level of stroke care, and then building on towards rehabilitation and getting back into the community afterward. You may have seen commercials on this. You may have heard of FAST. If you hasn't, this is an acronym that you really should get in the habit of knowing. FAST stands for face. Is it drooping or sagging? Arm, is it weak? Can I pick it up? Speech, is it garbled or slurred? If it's any of those things, it's time to call 911. People don't call 911 often enough. They wait it off, they go to sleep, they think they're just tired, even like it's just half of them that's tired, which is something we never understand. People have their family drive them in after the fact or wait to see if it's going to get better over the next couple of days, and that's absolutely the wrong thing to do. The number one thing you can do to help to save that brain function if you think you're having a stroke is to call 911. And the reason is that our time to be able to fix this is so time dependent. Like I said, there's so many parts of the brain that can be affected by this, but the quicker you open that up, the quicker that blood clot opens up, and there's specific things we can do for that, the likely it is that that recovery process can start faster and from a better base. So calling 911 is key to that. One of the things we're looking at from an administrative point is trying to figure out how best to design our systems to get people to the stroke centers that they need to get to that have access to those specific therapies. You may have heard of something called a clot-buster medication, and this is something called TPA. And that's been around since about 1995, when the first trials for this were done, where we looked at being able to give somebody a powerful blood thinner through an IV that will help to break up blood clots. And for a while, this was actually the only approved therapy we had for strokes. It works about 30 to 35% of the time. In those cases, it makes people better. It is associated with a risk of bleeding, and sometimes that can be serious bleeding, including bleeding inside of the head. But by and large, if you're having a stroke from a blockage and you get to us within a certain time, this is one of the most powerful proven therapies that we have. But it's very, very time dependent, and that time ticking starts from the very second the stroke happens. We can give this medication typically within 4.5 hours of symptoms starting on. That can be a big problem if you don't exactly know when the symptoms began. So if somebody woke up with their stroke symptoms, it happens sometimes during the night. We don't always necessarily know when that clock began ticking, and sometimes it's hard for us to be able to decide if a person is eligible for that therapy. The longer you wait, the less likely it is that the medication is going to work. So the quicker people get in and the quicker the system is put in place to be able to get people that therapy very rapidly, that's more likely to improve outcomes. Fortunately, we have other therapies available to us now. If you have a large clot blocking one of the large vessels, we actually have a special procedure called endovascular therapy. And this is one of the newest forms of research. It's been widely available here in Ottawa for probably around maybe 7 to 10 years, but really it hit its own about 2 to 3 years ago. And in certain clots, actually similar to what you can do in the heart, you can go up the artery with a special catheter. You can physically go up to the clot itself. You can put a stent across that clot and then pull the whole thing out, basically. There's other mechanisms to be able to do it where you suck the clot out with a tiny vacuum, but by and large, this is a way for us to open those very, very large blood clots that TPA and clot-buster medications don't necessarily work as well as. And in fact, Ottawa was one of the key points of research for some of the trials that helped to prove that this therapy worked. And I remember as a resident and a fellow being involved in some of the cases that we would enroll in these trials to help to prove that this therapy had fantastic outcomes. And we would see people go from being completely weak on one side to having almost no signs of weakness within the course of hours as opposed to months. There were several large clinical trials that came out of this proving that this worked. And this is one of those charts that we like to show. Basically what it's showing, this is a scale that tells you how well somebody's recovered. And the bigger the box, the more likely it is that you got to that outcome. And the further to the further to this side, the more likely you are to have a good outcome here. So these were people that you couldn't even tell they had a stroke. These are people that had to go to a nursing home or even died. And if you didn't get this treatment, you were less likely to have those good outcomes than somebody who did. And in fact, they were able to prove that in order to have one good outcome, you only needed to treat 3 people. So this worked well over 30% of the time, sometimes even 50% of the time. It had fantastic outcomes for this. We're also in Ottawa at the forefront of being able to try to define who specifically might be able to benefit from these therapies, even out beyond that time window. So I talked about 4.5 hours for TPA. In endovascular therapy, it's good for about 6 hours, but there's certain people we know might even be able to benefit from this even out to 12 hours, 24 hours in some cases. And we do have special advanced imaging that can help us tell what the flow is of blood within a particular part of the brain, what the volume is of blood, and how much tissue there basically is to save. So I was talking earlier about penumbra. We now have CT scans in the Ottawa hospital that can measure that, and there's other special computers that can even calculate for us. So there's special research going on to figure out how we can bring therapies like this to more and more people. And this is what it looks like at the very end. It's kind of gross, actually. But that's the blood clot sitting within one of those stents, and we like to take these pictures of these and share them around afterward when we're trying to talk about the specific cases that we've seen. But one of the research ideas that's been going around is trying to use the tissue that we're able to get from this to define what makes a particular clot harder to open up than others. So there's more avenues for research coming along there as well too. In the last couple of minutes before I talk though, I want to talk about some of the other therapies we have which maybe aren't quite so impressive in terms of pictures, but we understand are important nonetheless. And that gets to the idea of stroke units and recovery afterwards. So we talked a little bit earlier with Dr. Slack about some of the other partnerships that we have here in terms of stroke recovery and some of the partnerships that we have through groups like the Rehabilitation Center and other places such as that. But we know that having somebody on a dedicated stroke unit where they have access to physiotherapists, to occupational therapists, to speech-language pathologists, to the whole suite of interprofessional healthcare providers actually has almost as powerful an effect on people recovering from stroke as giving them one of these medications to begin with. And so another key feature that we're trying to do in our research at the Brain and Mind is to try to figure out how we can help to promote that. So working with our stroke unit teams in terms of our therapists to help to promote that process of recovery once the dust is settled from the acute setting. So trying to get all of these particular individuals who have a role to play with the patients and their families as they transition both from the stroke unit to rehabilitation and home. And one of the most exciting areas of research that we're coming across now, and one of the things we'll hopefully get a chance to talk about a little later, is how we can help continue that process once that immediate recovery phase is started and you start to go into the more chronic reintegration phase. How do people get home? How do we promote that recovery out weeks to months to even years afterward? So just to stop quickly there, we do have quite a lot of proven acute stroke therapies, but it's really exciting to be in a field where there's so much research going on to be able to help to continue that and continue that promotion of recovery afterward. If you aren't aware, and this is where my disclosure comes in, all of the research that we do is based upon best evidence, and if you're not aware of going to strokebestpractices.ca, all of the guidelines that we use in our Canadian stroke units and our Canadian acute care and recovery teams is all available online for public view. And with that, I'm going to stop there and let my compatriots continue, and I'd be happy to take your questions a little later on.
So thanks a lot, Dr. Blackier, and I'm sure you have questions, and he'll be available to answer some questions at the end of the session. So I'm really pleased to present our next speaker, Dr. Greg Selassie, who's an assistant professor in the Department of Cellular and Molecular Medicine and a researcher at the University of Ottawa Brain and Mind Research Institute and a member of the Canadian Partnership for Stroke Recovery. So what he's going to be looking at, and our next speaker, Dr. Lagasse, is once the brain damage has happened, are there ways to promote brain recovery after a stroke?
Great.
So,
Thank you very much. Can you hear me in the back? Yes, perfect. Great. So thank you all for coming today. As Dr. Slack mentioned, I'm a neuroscientist here in the Department of Cellular and Molecular Medicine. And my lab is focused on studying stroke recovery in animal models. And I'm one of about 10 labs here at the University of Ottawa that study stroke recovery in models. And specifically, my lab is interested in understanding how the brain generates movement, how it processes sensory information, and these two topics are kind of intertwined. They're linked closely together. And then also how we can use sort of novel approaches, sophisticated technologies to map how the brain changes after a stroke and how these changes facilitate recovery. So we've had a wonderful introduction to stroke itself. I just have this slide just to emphasize that stroke is caused by an impairing blood flow to the brain. And I have this nice image of a human brain. It's probably not the type of image that you're used to seeing because all the interesting cells, the neurons and their glia, have been removed. And what you're left with is this vast network of vasculature that supplies this organ. And it's quite amazing to look at this, and I think you can appreciate how such a complex network can sometimes encounter problems. So as we talked about, there could be a hemorrhage or an ischemic event that could be caused by a blockage or a rupture of one of these vessels. I didn't put this up here, but just why does the brain require such a complex network of vasculature? Well, it's a very energy-hungry organ. It needs a constant supply of nutrients and energies to function. It's been worked out that each individual connection within the brain, a synapse, is no more than 13 microns from its nearest vessel. So it just tells you that it requires such a constant supply of energy that the vasculature is an important component of keeping the brain healthy and working. So as we also heard, motor impairments are one of the most common features of strokes, and most people that experience a stroke do have motor impairments. And why is that? Well, one reason for that is because such a relatively large area of the brain is actually involved in controlling movement. Here I'm showing an image of the human brain, and there's a primary motor area outlined in yellow here. But there are also, and this area controls mostly hands and facial movements, for example. But there's also other motor areas, such as the premotor cortex, which help plan to execute movements, and then more specialized motor areas like frontal eye fields and Broca's area, for example, which generates speech. In addition, these motor areas interact with other sensory areas, such as the primary somatosensory cortex, as well as visual areas in the back of the brain here. But nonetheless, a large area of the brain is devoted to controlling movement. And much of our understanding of how this happens actually comes from research that was done right here in Canada quite a while ago. So Wilder Penfield was a famous Canadian neurosurgeon. He was actually recruited to Canada, and he established the Montreal Neurological Institute, where he performed most of his pioneering work. And he came to Canada with some very state-of-the-art techniques at the time that allowed him to probe how the motor system worked in humans. So he was able to actually to stimulate the brain in patients that were undergoing brain surgery, but the patients were awake while he was doing this. And as I mentioned, he was interested in the motor system, so he focused on this motor strip, as it's called, what's shown in blue in this image. And what he did actually is he held an electrode in hand and probed sites on that motor strip, stimulated them with electric current to observe what would happen. And what he saw is that parts of the body could actually be mapped onto this motor region. And it wasn't just a one-to-one correspondence between body parts and brain regions, but in fact, areas that that we have fine control over, like our hands and our face, have a disproportionately large representation within the motor cortex. So he was the first to generate kind of a map of the human body on the brain, and it helped us understand how the brain actually controls movement. Now, these were groundbreaking experiments at the time, and they still kind of serve the foundation of how we understand the brain controls movement. But these techniques, of course, had some limitations as well. They were quite invasive. So these were surgical patients that had a craniotomy, so part of their skull was removed so the brain could be accessed. He was also poking the brain essentially with an electrode that was in his hand, so it's quite invasive, and it was not very specific. The electric current that he applied to the brain could kind of spread through the tissue, and he wasn't really quite sure what exactly was being activated. Since that time, neuroscientists have kind of worked to refine these tools, to make more specific and less invasive techniques for probing brain function. And one such technique that I'd like to tell you about today is optogenetics. And this is a technique that we use in the lab to probe brain function in animals. Now, in contrast to electric stimulation with electrodes, as I was mentioning before, an electrical electrode, which could be a metal electrode or a glass electrode, is not very specific. So when it's applied to a set of neurons or cells in the brain, it stimulates all those neurons non-specifically. Optogenetic stimulation provides more specific targeting of cell populations. And it does this with light, actually. Optogenetics actually achieves activation of brain regions with purely just light, by shining light on it. And the way this is done is that there's a genetic trick that you have to play first. You have to get the neurons to be sensitive to light. Typically, they're not. The neurons in our brain are not sensitive to light. But by expressing a special protein on their cell surface, on their membrane, called an opsin, these proteins can render the neurons light sensitive. So when you shine blue light, for example, on a cell that's been rendered light sensitive, that cell will fire whenever there's a pulse of blue light. Conversely, there's another opsin that actually inhibits neurons when yellow light is shone on it. So for example, this neuron, when it's illuminated with yellow light, it inhibits its firing and becomes silent, essentially. So you can see that how this relatively non-invasive tool where we can use light to activate brain circuits as opposed to using electrodes or other invasive methods is quite a powerful approach for probing how the brain works. How does this actually work? Well, so it all comes down to having mice that have these light-sensitive proteins expressed in their cells, and that's what I'm showing in this slice here. This is a slice of a mouse brain. This is the cortex, the outer part of the brain, and these neurons, the ones that are fluorescent here, express these light-sensitive opsins, so they can be activated with light. And then you can kind of see in the image next to it, there's a beam of light. This is actually a laser beam that's targeted towards part of the mouse brain. And this is kind of maybe generates an image of how this laser beam is actually replacing the electrode that was once had to be used to activate brain circuits. So how can we use this technology to learn about stroke and stroke recovery? Well, what we do is we can actually map out the motor system in rodents. Similarly to the Dr. Penfield's tools, we can generate motor maps in our animals. There are two key differences between our work and Dr. Penfield's work. One is that the animals are anesthetized. So we're not working with awake patients as Dr. Penfield was, but these mice are actually anesthetized. And the second feature is that we're not really mapping out the entire body representation. We're focusing on the forelimbs of these animals. So what we have here is a mouse that's anesthetized, and we're going to probe various brain regions with this laser light, this blue laser light. And we have some equipment in the lab that kind of automates this, and you'll see a movie here in a second where this beam is guided to various parts of the mouse's brain. And what we're looking for are sites that evoke movement of the limb. So which part of the brain do you have to stimulate to get this limb to move? And I'll just show you a movie here, and you can kind of watch the limbs move, and some of the stimulation sites, you can see a slight twitch, jerk movement of the limb. It's a very small and rapid movement, so if we use some high-speed cameras and film them and slow them down, you can see that there's actually a quite large displacement of the limb that's evoked purely by shining light on that mouse's brain. So what this tool allows us to do is to generate kind of a motor map for that limb. So for example, we can depict the representation of the left forelimb, for example, on the mouse's head. So these are the two hemispheres, the left and the right hemisphere on the mouse's head, and we can then assay which of the sites control the left forelimb. And what we end up with is this motor map where the hotter the pixels, the larger the movement that we could record from that animal. So there's this hotspot in the right hemisphere that is really good at evoking movements from the left forelimb. So this is how we kind of map out motor representations within our rodent models. How can we use this to study stroke recovery? Well, we also need, then we have a very a nice map of the forelimb. We need a way of targeting stroke to a known brain region, and we have tools for doing that as well. Essentially what we do is we inject a dye into the bloodstream of the animals, and then we can activate that dye with a laser that's targeted by us to create a stroke in a very specific brain region. And I'll just show you a movie here of what this looks like. So what you're seeing here is blood flowing through vessels on the surface of the brain, and that laser beam is being moved over that blood vessel to cause a stroke or occlusion in that specific part of the brain. And then just next to that, you see an image of again, the sort of top-down view of the mouse's brain, the two hemispheres, the left hemisphere and the right hemisphere. And what we see here outlined in white is the part that's lacking blood vessels, because that's where we created our stroke. That's a stroke in the motor cortex of the mouse. So then we have kind of all the tools lining up. We can map out the motor representation on the mouse's brain. We can target strokes to parts of that motor map. How does that map change after a stroke, and how does that relate to recovery? So here's what we have. This is average data from a large group of animals. And again, we have a baseline motor map where there's this hotspot for controlling the left limb. We then targeted a stroke to just those pixels that were red here before. So we just created a stroke in this area here. And surprisingly, what we found is that this whole hemisphere kind of went silent. So it's no longer evoking movements, even when we stimulate all these sites around the stroke itself. We were quite surprised by this. We thought that maybe there would be sort of a migration of active sites, but nonetheless, we found that there was very little activity in that injured hemisphere. We know that tissue is not actually damaged. It's actually viable. It survived, because we can actually record electrical activity from that brain when we do our light stimulation. So this is done with EEG, or electroencephalograms, which you might have heard about. And what we can do is we can actually evoke a large deflection in this EEG signal just with our light pulse that's shown in blue here. And what we see is that compared to our baseline maps, so if we look at the size of this EEG deflection and plot it as a heat map here, we see that there's fairly good light evoked activity in both hemispheres. And after stroke, there is a hole kind of where we caused the stroke, so that tissue is no longer viable. We can't stimulate with light anymore. But the surrounding tissue is actually quite fine. You can stimulate with light and evoke activity. It's just not producing movement of that forelimb the way it was before stroke. So this presents a very valuable platform for us, because it now lets us evaluate how therapies can improve function. What I failed to mention, I guess, is that these animals did not receive any other interventions at all. They were just given the stroke and then left to recover spontaneously, essentially. And so we think that if our job now is to somehow recruit these peri-infarct, as it's called, or near the lesion, these sites, to once again contribute to motor function of that forelimb. And this could be done through rehabilitative training, for example, so training the animals to use that forelimb repeatedly, or perhaps through some sort of non-invasive brain stimulation, and Dr. Lagacé will mention this in her talk next, or perhaps a combined treatment where you combine non-invasive brain stimulation with rehabilitation. But this is the task that's ahead of us, and I think our tools that we have so far in the lab allow us to test whether any treatments that we evaluate are actually efficacious. So that's one way of mapping out how the cortex controls movement, is by stimulating the brain and looking for the movements that you can evoke. A complementary technique that we also use in the lab is to actually image brain activity, similar to the way fMRI is used to image activity in humans, for example. And to describe how we use this, I'll walk you through a paradigm that we use in the lab. And here we're using mice that we train to do a simple behavioral task for us, to use their forelimb. And these are awake mice, and so they're trained to pull a lever to get a water reward. And we do this in about 20-minute sessions where we put them on a task, and their job is to grasp this lever here and pull it into this rewarded position indicated by the blue box here. And as soon as they complete that, they get a drop of water. And they can do this several hundreds of times, and with training, after several days of training, they complete almost 100 trials, of successful trials per session. So then we can ask, how does a stroke impact the function of the forelimb in these animals? And to combine with that, we can also image their brain activity. We have an indicator expressed in these mice that lets us visualize active brain regions while the animals are performing the task. So what I'll show you in a second here is a movie of the two hemispheres of the mouse brain. And this movie was created while the animal was performing a single trial of this lever pulling task. So at time 0 here, when this movie rolls to 0 seconds, that's when the mouse actually pulls the lever in the task. And what you're looking at here is a top-down view of the mouse's left and right hemispheres. And what we'll see is that there is this large activity in both hemispheres in what's the sensory motor region as the animals are completing this behavior. So again, this gives us a unique opportunity to map out how motor function activates the brain, and then, as you'll see, we target a stroke to that active region, and we can look for reorganization that's associated with recovery. Now, in this case, we didn't actually just leave the animals to recover spontaneously. We actually worked with them every day. We trained them on this task after the stroke to try and get them to improve. So what I'm plotting here in this graph below is their performance. So at baseline, they're doing almost 100 trials per session. They're quite impaired after the stroke. Day 3 and day 5, they've performed less than 50 trials. But with repeated training and testing daily rehabilitation, they actually recover back to their baseline levels by week 8. So the question is, how did the brain remap? What kind of changes occurred in cortical activity that facilitated this change? And to do this, I'll show you sort of snapshots of these movies, just like I was showing you before, just so it's a bit easier to see exactly what kind of brain reorganization occurred. So here's that baseline condition again before the stroke, and what we see is that there is this strong activity in the sensory motor regions of the brain immediately after the animals performed the lever pulling behavior. We targeted this region with a stroke, and you can see this white circle here that delineates the stroke. And what we find is that in the early period after the stroke, when the animals are still quite impaired, we don't see much activity in this injured hemisphere again, kind of like in our motor mapping results. There's a little bit of hint of activity, but it's not very strong. The dominant activity comes from the contralateral hemisphere. But by week 6, once the animals have recovered to fairly good performance, we start seeing areas in the injured hemisphere becoming active again as the animals are executing this behavior. So we think that this is perhaps a mechanism for how the animals can rehabilitate themselves and recover function that's lost after a stroke. Excuse me. I should also point out that there's also this robust overactivity of the non-injured hemisphere. This kind of jumped out at us as well as surprising. So there's this overactivity, especially in the early period of the intact hemisphere. And looking through the literature, it's obvious that this has also been reported in human stroke as well. So this is data from functional magnetic brain imaging, where people are within an MRI magnet and they're performing a unilateral, like a finger tapping task like this. And what's typically observed in healthy subjects is that the contralateral hemisphere has activity in its sensory motor regions. In an individual impacted by a fairly large stroke here, what's observed is that there's activity in both hemispheres, especially in the early phase of recovery when impairments are quite severe. So we think there are some parallels between our mapping studies that we can perform in mice and rodents and some of the phenomena that are observed after human stroke. And we think our animal models serve as a platform for testing therapies and ways of improving recovery. So in summary, I think I've shown several examples of how novel technologies like Optogenetics allow us to study brain reorganization in unprecedented ways. We have evidence that motor practice can help recover lost functions. And our animal models can be used to evaluate treatments that combine perhaps rehabilitation with non-invasive brain stimulation, as well as regeneration, which we'll hear a lot more about in our next talk. So thank you very much, and we'll take questions at the end.
Thanks very much, Greg. So if you have questions for Greg, we'll save those for the end. And now I'll introduce our next speaker, Dr. Diane Lagasse, who's an assistant professor, also in the Faculty of Medicine, a researcher at the University of Ottawa Brain and Mind Research Institute. She's also a member of the Canadian Partnership for Stroke Recovery and a pillar lead for the stroke pillar at the Brain and Mind Research Institute. And her focus is also on looking at novel ways to promote brain recovery after stroke. So thank you so much.
So good evening, and I also want to say welcome and thank you for coming, especially on not the nicest of nights outside. So today what I want to talk to you is about regeneration in the brain. So as you might be aware, we've known for a long time, or most people believed, I bet when most of you were in school, you would have been taught in the brain, once you have a certain number of cells, that's all the cells you're going to get. You only get a certain number of neurons after you grow up. You're going to have those neurons for the rest of your life. And if something happens to you, like a stroke or a neurodegenerative disorder, and those neurons die, right now, there's no way to make neurons, right? So it was even as early as the 1920s, the famous neuroscientist Cahal, this is actually pictures he made of the cortex that Greg was talking about. So the cortex being that outside layer of your brain, it's actually Latin for bark. If you peeled it back, you would see your cortex, right? And it actually, he said that everything must die, nothing may be regenerated. And it is for the science of the future to change this harsh decree. So it did change. It was actually in the 50s that people first started to realize, scientists in labs, in preclinical animal models, for the first time showed there's dividing cells in the brain. And then in the late 1990s, this was shown in primates. And when I was a graduate student, also in the late 1990s, I was overwhelmed one day when my prof came in. We had all spent hours preparing to this one paper that we were going to talk about. And he put this paper down and said, this is what we're talking about today. This is going to change neuroscience. So the article title was Take Comfort in Human Neurogenesis. Why take comfort? It was the first time in the human brain that there was the discovery of brain cells actually dividing and giving rise to new cells. And let's face it, this could really change the landscape of recovery from stroke and many things. So I know you're bright, and if you're thinking that was when, and where are we now? I haven't seen a huge change in the landscape in using stem cells or regeneration. So I'm going to talk to you tonight about where we are in the field. We've made a lot of advances. We now know that actually neurogenesis changes by a lot of things. So if you had to guess, what do you think happens if you age in terms of the number of newborn cells? Would it go up or would it go down? Down. Exactly, it goes down. And as my parents sometimes say, like most things, it goes down as you age. And I say, no, that's just because you're really bright and you don't need more new neurons because you already have so much information in the ones you have, you don't need any more new ones. So it does go down. What about stress? Stress actually decreases the number of cells, okay, as do drugs of abuse, as do many things. When I go to the high schools and I talk to students, sometimes that actually kind of makes them, ooh, really? If I drink too much or if I use drugs of abuse, drugs of abuse is a huge, it just turns off the birth of newborn cells. If I show them an animal picture of how many cells you have and then say, if you do cocaine, this is how many cells you have, a few of them look twice, I think. So it decreases it. What about exercise? Exercise, good for everything. Well, sure enough, good, it also increases. Every time we exercise, we increase the number of newborn cells in animals. So as many of you know, part of rehabilitation is exercise. So that got people really excited, right? Thinking that Excitement in recovery is part of it, is exercise and increasing neurogenesis. So what happens in the brain after a stroke? So right now I'm talking about ischemic stroke, right? Where you have a damage in one area, often in the motor cortex. Your opposite side is affected because we know our right side of our brain controls the left side of our body, right? What do you think happens to the number of cells? How many people here think it goes up? How many people here thinks it goes down? And how many people hate that I'm really interactive? It's okay. That's what I tell my students. At least you're not sleeping. There's a good thing from that. It actually goes up. After a stroke, it goes up. And that finding alone made me want to invest my career in trying to understand it a little bit more. So it was actually first shown again late 1998, 1998 in a gerbil model. The gerbils had strokes, and what they showed, this is another part of the brain of the gerbil called the hippocampus. You haven't heard about that tonight, but it's a deep structure inside your brain that's really important for learning and memory. And this, hopefully you can tell, this is a control animal. All these little black dots, you're going to have to believe me because I don't have time to take you up to the lab to convince you of it, are newborn neurons. But here is 2 weeks after a stroke. Look at how many more little black dots there are. And this is in a part of our brain that is important for learning and memory. Okay? It's not even close to where the damage is. So if I can't get you excited about that, maybe this will excite you also. So this is another part of the brain. This is a coronal section of a brain, taking a brain forward and cutting it like this, exposing what here is the two ventricles that actually hold our cerebral spinal fluid. So that's the liquid that goes around our brain. Every one of these green dots here, this is a special mouse. Again, we have a lot of special mice that allow us to see things. Every one of those new green cells is actually a dividing cell in our brain, okay? So in a normal brain, you would have both our ventricles. We have lots of newborn cells growing right beside where actually that liquid is. But what happens if you have a stroke? Here's the stroke right up here. So this is the motor cortex. That's actually where the infarct is, the dead tissue, and the penumbras around it that you already heard about. And look at, the green cells actually migrate right up on their own. They go up to surround that damage. They do this without us doing anything to them. Those cells usually are fated to go towards our nose, our olfactory bulb. In a mouse, I can kind of understand that because their nose is really important. And they generate new cells. We think there's a turnover of about 10% of the cells in the nose of actually a mouse. But in a stroke, what happens is they take those cells and they push them up right towards the site of injury of the stroke. So the cells migrate on their own. And I believe that there's no way the brain would do something like this unless it had some ability or it wanted to repair itself. Why would it spend so much energy to allow those cells to go up there unless there was a function for those cells? So here's the bad news, is that once the cells get up there, they die. About 80 to 90% of those cells die. They make it all the way up there. And if you wait long enough, they die. So the cells actually, even though there's lots of them there in the original population, there's something that doesn't allow them to integrate, right, and to make functional newborn neurons on their own, right? Most of the time, they just don't do this. So my lab was set out to try to understand if we could then, when I started my own lab here 10 years ago, what I wanted to do was ask a very simple question. And I can't do this in a human, okay? We can't image the cells in a human, first of all. It's very hard to image these newborn cells in the brain. So in animal models, I want to ask the question, do the cells, if I can make them survive, or if they survive, do they make a functional neuron? No one in the world, even though most of them die, the ones that survive there, no one was able to actually patch onto them and see actually what would happen. And why was I able, as a new investigator here, to be able to do this is because we have a great team of people here working in the field of stroke. And one of those is my collaborator, Jean-Claude Bigue here. And then I recruited a great postdoc from the BC, Dr. Tamal Karangara. And what he is really good at is taking the brain, making those slices, and then putting them on basically what we call an electrophysiological rig here. So he has a slice in here. Here's all those green cells that I was talking to you about. And what he does is he takes a glass pipette and he actually just connects right with the neuron. And he's trying to see, can that neuron fire? So some of those cells make neurons. Most of them die, but some of them do. I was wondering, can they fire at all? Because if they can't fire at all, there's no use in us trying to make more of them, right? I need to know, can they fire at all to start with? What he showed in the first time, and we published this last year, is that some of these cells are excitable. So about 3% of the cells, he can see them actual fire. They have electrical impulses, and they can actually fire, okay? So this took him about 3 years. So research, basic biomedical, especially preclinical studies, take a long time. It took him a long time to figure out how can he, just to even take a slice and with a big hole in it, and then be able to patch onto it to see if actually, the day that he got this, after about 2 years, he told me, Diane, I need a career, I have a family. And we said, we know, but if you get this, it will be big. And it was big. So we showed that they could fire, which then made me right away, and all of us want to know, what now if we can make more of them? So they can function, they can fire. So what if they didn't die? And the cool thing about working in preclinical science and with animal models is that you can almost always make a mouse now to do something that you want it to do. So I could have a model where I could prevent them from dying. I actually got this model from a colleague of mine, Amar Sahai at Harvard University. He was a postdoc also around the same time as I was. He has his own lab now. And basically, what we do is make these transgenic mice where we can insert DNA into them to change them so that we can look at specific questions. In this mouse, all those newborn cells are green, okay? We've done that through this part here, and I don't need to explain all of it. But this part here is the cool part. We actually take away a protein called BAX, its ability to make BAX. Why BAX? Because BAX, we know, is essential in how those cells die. Part of the mechanism that allows those cells to die is because they express this this apoptotic protein. So we take it away, and now the cells are going to survive. So we got these mice here. Here's a picture of again, the coronal section of the brain, so cutting it through. Probably getting used to this now. Here's the ventricle. The newborn cells are here, and this is the stroke up here. And each one of these, this time I got it in brown for you. Sorry, I'm kind of confusing you. Each one of these brown dots is a newborn cell that has gone up. Now, this is my control. Guess what mouse this is? Here's the Bax mouse. Look at how many cells now. 8 weeks after stroke. Thousands of cells. Because they keep coming up, this mouse won't let those cells die. Now we have lots and lots of cells there. So now we want to say, now it's getting fun and exciting. My PhD student is very happy. I never imagined it would look like this. When you know you have something good in a lab is when you look under the microscope at the slide and you can tell which mouse it is without even knowing its genetics, because you could just tell this is a mouse that Bax has taken out and the cells now can survive. So what happens to the mouse after a stroke? We want to measure its recovery. So you might say, well, how do you measure recovery in stroke? We have really good preclinical tests that have been shown to work, and this is one of them. It's called the tape test. It might seem silly, but it's not. You put a piece of tape on the animal's paw, and the animal actually is going to remove the tape. So here's a movie of it here. It's struggling to get that tape off its paw. It's not very happy with us. We put it on there, and it will take it off. It usually takes, maybe about 10 seconds to take it off if it's healthy. After stroke, it can take anywhere up to 1 minute to take that tape off its paw. Okay, so it's a very sensitive test. Another test is called the cylinder test. Again, very simple. The animal's within a cylinder, and it's just spontaneous use. I kind of think of it like when I'm in my kitchen and I'm grabbing with my right or my left hand to grab the cupboards, which one am I going to grab with? It's interested in the cylinder, so it looks around with it. And we see how much time does it spend on either its right paw or a left paw. So if we give a stroke on the left side, it's going to spend a lot less time on its right paw. It just naturally won't use that paw, right? It just naturally doesn't want to anymore. What about the ladder test? So you can see that these rungs of the ladder are irregularly placed. Can it walk across that ladder after it has a stroke? Or does it make a fall? And there's big falls like the one you could see and the one up here that are really easy. And then here's, what we call a slip, right? It's not an obvious huge fall, but it's not grabbing the rungs like it usually would. So mice usually make very few errors in this. They're very good, as those of you who have had them ever in your kitchen, they run around quite fine. They know what to do to get out of the things and crawl on things. So on all of these tests, after the stroke, as I told you, in the adhesive, for example, they were up around 60 seconds. All the mice were like this, right? So after the stroke, whether they, had the backs or not, they were the same. And the recovery actually, well, the backs did do a little bit better. They could take it off a little bit quicker. But it was pretty disappointing because really, there was no significant difference. This happens in basic science. It happens in clinical science. You might be well aware of things that we've tried in humans that don't work. And my PhD student was pretty disappointed. This is 2 years worth of work, a mouse model, and lots of excitement. But I told her, you know what? I'd much rather know this now than know this after we discover a lot of drugs that can maybe increase the number of cells. It just tells us something really important. It tells us just making more of those cells isn't going to be enough. It's not just the number that matter, right? So just actually increasing the number of cells is really insufficient on its own to promote recovery. So it got me thinking and got us in the lab thinking a lot about maybe the cells can't integrate. And it kind of comes back to some of the things Greg is talking about what's actually firing in the brain after the stroke. Are those cells actually being utilized, right, after a stroke in order to improve recovery? And it made me think a lot back about development. So I don't know if you knew this, probably you might, that actually when you're born, you have a very few number of cells. When you're about 6 years old, this is one picture of how many approximate relative number of neurons you might have in your brain. Around 14 years, you have less. It's something called pruning. So you utilize neurons, and by utilizing you keep those, but you actually lose a lot. And we think of it as actually the brain becoming more efficient. It just keeps what it needs, right? We often talk about it like you use it or lose it. And for those of you who have teenagers, you'll be happy to know that the higher order cognitive centers, like our prefrontal cortex and things like those centers actually continue to prune throughout adulthood. And myself with 2 boys, I was very happy to know that boys, this happens later. So when I see the girls that seem a little more mature, I'm like, he's still pruning. It's okay. It's going to work out, right? So I thought maybe, are we really utilizing those cells? And Greg has already told you about something that's really exciting in neuroscience, this idea of optogenetics. So using light to actually stimulate the neurons. So we can use light and actually stimulate them and ask if we utilize those cells, could those cells improve recovery? And that's what we're doing right now. So we're optogenetically stimulating now these newborn cells. This is a mouse within its cage, and it has stimulation fiber, and it's getting stimulation in its home cage. And then this is an animal that we're doing stimulation while it's actually in the middle of performing behavior. So we're trying to understand if we actually stimulate those newborn cells, especially the ones that we have lots and lots of those newborn cells, can we improve recovery? Now you might say to me, as my family and other people, I do talk about my work outside of here, and my friends say, well, you're not going to do this to a human, and I'm not signing up to have this done to me. And you're right. I would never think that we're going to use optogenetic stimulation in humans. It's a tool for us to ask a specific question to know what stimulation is doing. And what is happening, including here in Ottawa, is there is non-invasive stimulation therapy, like clinical trials ongoing to try to understand if stimulation can improve recovery. And this is happening throughout the world. There's been varied results, some good, some not so good, but we don't actually understand why. And I think some of the reason why is we actually don't know yet what cells do we really need to stimulate to improve recovery. So this is TMS using a magnet or direct current stimulation therapies, and these are going on in the School of Rehabilitation Science and Clinical Science, Francois Tremblay's work. So what I've tried to do tonight is to tell you a little bit about the story of our discovery in our lab here, where when I first saw this image, I was immediately convinced that this was something that I wanted to spend my career working on, because I believe that the brain already works pretty hard to put all those cells up there. The cells actually can fire. The ones that survive, we can get some of them to fire. And we've made a mouse model where we have lots of them, and we know that if we just do that in terms of a drug therapy, if we can give you a pill that might make lots more of them, that's not going to be the cure in terms of probably promoting recovery on its own. But maybe if we combine that with stimulation and other things, those cells actually may be able to integrate into therapy. So I would have never imagined that I would have an animal colony downstairs in a lab and I would have work with animals. But I really do believe that these kinds of studies are the ways that we're going to be able to progress stroke recovery. And this is stroke recovery for people that have long-term disability, that are, you know, I had both my grandmothers had stroke, and one of them was very severely affected for many years. But also what I worry a lot about is our children that are having strokes. So there's more and more children coming into CHEO Hospital with strokes. So we have a huge problem there. And this, you know, is really alarming. And the good thing for those kids is that actually they recover a lot better usually. They actually are responding. There's some work in Calgary being done with stimulation therapy with those children. And the nice thing, and they have a lot of potential with probably a lot more stem cells in their brain. I've today talked to you about endogenous stem cells. And in stem cell therapy for stroke recovery, I'm sure you've heard about some of it. If you didn't hear about Gordie Howe, you've heard about something about stem cell recovery, right? So I've talked to you about sort of the area of research that's looking right now at compounds to promote neurogenesis or endogenous stem cells within the brain, because now you all know that you have stem cells in your brain. But there's tons of other research going on, right? There's work with mesenchymal stem cells, bone marrow, umbilical cords. There's a huge area of the hospital here at OHRI, just next door at the General Hospital, Dr. Bill Stanford, Jing Wang, that are actually making induced pluripotent stem cells. So I didn't want to make this talk too long, but what that is they're actually cells that you take a cell that's differentiated and you can make it back to a stem cell, and then you can make it into a neuron, all of this in a dish, and then you can transplant that into the brain. Okay, so there is tons of work going on in the area of stem cell research. So I just wanted to highlight a lot of the people who've done this work. Maheen Caesar, Tamal I mentioned, also Patricia and Sebastian are some of my graduate students that are here and are upstairs afterwards, going to show some of their posters. We actually have many of our research students upstairs, so hopefully you can grab a coffee and look at some of their work if you're interested. Also, thank you, because you might know it, but you know, your tax-paying dollar funds the research that's ongoing here. So the work is supported by the CIHR and NSER, Canadian Foundation for Innovation. And really the work here is a lot driven by the brain and mind. As Greg mentioned to you, there's about 10 of us that have very active labs in the field of stroke recovery and preclinical models. Many more labs also doing clinical work. And I love being here. Why? Because I really do believe in team. Together we achieve more. So, you know, I can talk to the people in engineering about the light stimulation. I can work with Greg and understand more about the signaling and what's happening in terms of reorganization. We have clinicians, we have researchers, we have rehabilitation scientists, and together we meet and we discuss what are we doing and where do we want to go. It's also a big week here in Ottawa for stroke. We actually are right now hosting the 9th Canadian Stroke Congress. So this is, everyone in Canada is coming to Ottawa to learn about what should we do in stroke care in terms of both acute care and then also in terms of rehabilitation and recovery. So we're just going there tonight, many of us. So to end sort of with the question that you came to hear about or why you signed up, can the brain repair itself? So I leave it to you to make out your own mind, but I would say that we know that in all patients there is some levels of repair that happens endogenously. You've probably seen it yourself. If you've had a stroke or you know someone else, even if you didn't do anything, you will see some degree of recovery. And I believe that that's due to some of the innate mechanisms that we have that drive recovery in our bodies. And I believe it's yes, and we're really trying to discover ways to harness that, because we know that it only occurs usually during a very limited time after stroke. So thanks again for coming, and I know all of us are very welcome to answering any questions you might have.
So thank you to the speakers for great talks. And now we have time for questions. So if anybody has any questions, we have microphones around, and we're happy to answer anything to do with the clinical situation or some of the studies we do in the lab. Okay, we have a question over here.
Can I ask a very simple question? Between two campus, civic and general, according to the stroke team, which one is the choice because we want to save time. This is the first question, practical, between civic and the general. And the second one is between TPA and interventional. I know there are many factors, patient factor and the stroke location, and also other comorbidity. And what is the choice now? To go directly to interventional or try the TPA first?
Sure. So those are both excellent questions. So first of all, stroke care, acute stroke care in the city is organized so that our primary stroke center in the city of Ottawa is the Civic. So if you call 911 and you present with stroke symptoms and you're within a potential window, and we have algorithms to help to decide who that is, regardless of which part of the city you're calling from, or even if you're from one of the outlying centers, so coming from Arnprior or Perth perhaps, you're going to be directed to the Civic specifically. So there is some capability at the general, but by and large, all of the interventional suites, all of the stroke team is centered at the Civic Hospital. And that's not uncommon for cities that have several hospitals in place. That things tend to get clustered at one site. And because neurosciences is focused at the Civic in terms of the clinical work, that's where stroke patients tend to end up. Your question about the question coming up about whether a person might benefit from TPA or thrombolysis versus endovascular therapy, that's an excellent question, and there's all kinds of research going on in terms of how we try to select patients for it. The best differentiation between them is the size of the stroke and where the clot happens to be. So a very large clot lodged in one of the main blood vessels, so the middle cerebral artery, for example. If there's a large clot lodged there, that's something that we can go in and chase afterward with endovascular therapy. So those people might be very well good candidates, if everything else aligns just in the right way, to be able to go up and physically take the clot out. Somebody with a very small, what we call distal clot, that's maybe not quite as large or is in one of the smaller blood vessels, it's not very easy to get up there. So they might not actually be candidates for endovascular therapy. But those smaller blood clots tend to work very, very well with TPA. So it depends a lot on the size. It depends upon when people present. There's other factors. So if you're taking a blood thinner already, you might not be a candidate for TPA, but we can still go in with endovascular therapy. So that's one of the things we're trying to determine, is whether a person might be a candidate for one, the other, or both. And in fact, there's a lot of research going on trying to determine whether a person can get TPA and then go on to endovascular therapy, which is our standard practice right now, that we'll try to do both if we can.
Questions? Right here. We'll get you a microphone.
You said stroke with the children are increasing. I wonder why it is that and what can be done to prevent.
Probably better than
Yeah, so stroke can happen in any age. We know that even newborns can have strokes. The youngest person I ever treated with endovascular therapy was 16 years old and who made a complete recovery, by the way. In a lot of the cases in younger people, the reasons why somebody might have a stroke are different. You're more likely to have things like congenital heart defects. You're more likely to have genetic conditions that might make somebody more prone to form blood clots, say. So it's not always the case that it's the same risk factors as in adults. There is, of course, the trends we see towards more people developing things like higher blood pressure, diabetes as children. So we do notice that there's a trend in that as well, too. But by and large, the cause tends to be a little bit different. The biggest problem in pediatric stroke is recognition of it, because people don't expect kids to have stroke. So somebody coming in with stroke symptoms might not necessarily get recognized the same way an older person would. And so a lot of the research is trying to focus on how do we recognize things in time that we can then make a difference for our acute interventions. And then promoting the recovery afterward with that.
So question here is on the severity of a stroke. Do you see a relationship between the severity of a stroke and life expectancy after a stroke?
We always leave our clinicians.
Yeah, that's okay. No problem. So the answer to that is yes. The size of the stroke or the severity of stroke is absolutely relation to the complications that can come after it. So somebody who has a large severe stroke is more likely to have the acute complications afterwards. So if you have difficulty swallowing, you're more likely to develop a pneumonia afterward. You're more likely to develop something like a blood clot in your leg from not being able to move it as well. And that is tied with life expectancy. We know that if you've had a large stroke, you're more likely in the intervening 5 years to have something else happen or to even have an increased cause of mortality with it. So it is something that if somebody does have a very large stroke, then yes, they are more likely to have the complications, and some of those complications can end their life afterward.
I'm a physiotherapist who works with stroke in the community, so my question is more related to the rehab and recovery. So thank you so much for bringing all this, because we definitely see the positive outcomes. My question is, you mentioned, Dr. Dillon, that some research is being done on continuum of care for the stroke units. So when the patients are discharged from the hospital, how does that work? Because it's hard to collaborate stroke units in the community.
Mm-hmm. So one of the things that my colleague, Dr. Dola Shahi, who some of his students are here having posters tonight, they're working on projects including something called Recover Now, which is trying to get more of an independent focus for ongoing rehabilitation, specifically with speech therapy, but also with some of the other interventions with physiotherapy and occupational therapy as well. And they're trying to do that through a variety of technology-assisted platforms, basically somebody at home with the use of iPads to be able to have a program to help them work with this program, feeding back with a therapist as well to continue that intervention onward. And that's a really exciting field to be able to get people, because we know it's hard to get people into inpatient rehabilitation. People always feel like they can benefit longer afterward, but it's hard to be able to spread those resources out. So if there's ways we can get people the ongoing therapies, even if they're not physically within the walls of an institution, then our hope is that that's going to help to promote that recovery and help that continue as well.
I have a few questions. So for the mouse model, so first of all, the light that's shining, that's through the skull, right? There's no, it's all going through.
Correct.
There. Okay. And then on the slide, sorry, I've forgotten your last name,
Greg.
Dr. Dillon. On one of the slides that you had of the brain where you were showing the activity between the movement of the limb when they were lighting up.
Yes.
There were all these other slides that had like T minus 1 second.
Right.
What were all those other ones?
So those images were kind of snapshots of the ongoing activity that we record during the experiment. So the brain activity we record live, kind of like a movie of a camera pointed at the mouse's head, and then those frames were sort of snapshots at various intervals before the animal engaged in the behavior, during the behavior, and afterwards. So it was a time series essentially.
Okay,
Yeah.
that makes sense. Just the last question for everybody, maybe. So you were talking about, and you've been talking about recovery, and it's wonderful. But so how does that relate then to the whole concept of neuroplasticity, which you haven't brought up, which is like years later when we don't know necessarily that it's vascular anymore or anything, right? How does all that recruitment relate to some of the things that you mentioned?
Right. So definitely neuroplasticity is one of the known mechanisms that mediate some of the changes that I showed, for example, in even the motor mapping experiments, as well as the imaging experiments that you had asked about. And what we know is that the plasticity can occur at many different levels. I'll speak about my experiments. Those are mostly probing the cortex, as we discussed, the outer layer of the brain. But there are deeper structures that can take over some of the functions that are lost after even cortical injury. And just our experimental limitations don't allow us to assay those changes as easily as the surface changes. There are even changes that can occur as low down as the spinal cord, for example. So there can be rewiring at the spinal cord level that allow for recovery to occur as well. There can be structural changes. There can be new axonal branches that can sprout within the spinal cord to facilitate recovery after stroke. So definitely neuroplasticity is a major mechanism that mediates these recovery processes.
Cholesterol is needed for the brain, and yet it's not necessarily a good thing for the heart and cardiovascular. How do you balance those two requirements or those two challenges?
Sure. So as risk factors go for stroke, we know that blood pressure tends to be a more important one for stroke specifically. So we all know that there's a certain amount of cholesterol that's good and healthy, and we know that high density lipoproteins, the so-called good cholesterol, is important in promoting cardiovascular health. What we tend to do in the clinic is we tend to look at the levels of low density LDL, the so-called bad cholesterol, and we have evidence that suggests that getting it below a certain target, so not eliminating it entirely, but getting it below a certain target seems to be promoted with reduction of risk. And it tends to be tied to things like how much plaque you have in your arteries at a specific time. So somebody who has very smooth arteries that doesn't have a whole lot of plaque, we're less worried perhaps about the level of cholesterol that's there versus somebody who has quite a significant amount of plaque that's very complex, that has lots of ulcerations, that basically a blood clot could break off fairly easily and go to cause that problem. So it does tend to be very individualized. So we tend not to focus so much on trying to eliminate it or so much on trying to be dogmatic about it, but trying to put it in the context of a person's broader risk factors. Somebody coming in with a slight elevation in their cholesterol but a much higher blood pressure, I'm going to focus most of my attention on the blood pressure, for example.
Any other questions?
We've got a waving hand over here.
Oh, gosh. They're telling me to. Okay. This lady has a question.
Hi, thanks. That was really impressive. I have two questions. One's more of a general question and a bit of a corollary to a question that was asked about when a person has a stroke and the chances of having a second stroke increases. My question is, does it decrease over time, that chance of having a second stroke? So that's the first one. And the second one is more research related. With the research going on, is there any difference, or does gender make a difference, gender of the mice?
So maybe I'll address the first question, and then we'll maybe open it up broader to the second one. So the chance of having a stroke is absolutely higher if you've had one before. And the answer to your question is yes, it's very much tied to the timing of it. And in fact, it's almost a very narrow window. So the highest risk period if you've had a stroke of having a second stroke is actually in the first 24, 48 hours after that first one. And that can, whatever it is that's caused that first stroke, we think is still active. For example, if you have a large clot sitting in your carotid arteries and it breaks off and causes a large stroke, well, that carotid artery is still active. Well, you'll hear us use the term hot carotid, for example. And we know one of the therapies for going to fix that is doing a surgery called an endarterectomy or a stent, where we basically open up the vessel, clear out the crud, and close it out. We're very glorified plumbers to some extent in some of what we do. But we know that the sooner you do that after a stroke, within reason, the better off you are. And in fact, the benefit of doing a procedure like that actually starts to significantly decrease the further you wait. And it's actually about 2 weeks afterward. In our stroke prevention clinic, we try to get people in with the high-risk strokes as quickly as possible. If at all possible, they're seen within 24 to 48 hours, and certainly within a few days to try and enhance that benefit if we can all do it. Once you get out past that window, if something hasn't happened by then, your chances of it going on start to go down a little bit day by day. And if you get out to about 6 months after it, we start to be less concerned about a possible recurrence of the stroke from that versus something happening quite immediately. I do have things to say about gender, but maybe we can go from okay. So the answer to your second question as well is yes, it is very much tied to gender as well too. And this is actually one of the Canadian Stroke Congress was mentioned as something that's coming up, and there's a whole workshop set aside, and there's been whole reports dedicated by the Heart and Stroke Foundation to understand how stroke behaves differently in women especially. So the risk factors are perhaps a little bit different. The recovery is a little bit different. The societal implications, in fact, are even a little bit different because there's a whole host of other factors that go into not just how people recover from stroke, but the challenges and adversities that they have from a social context in terms of accessing that recovery as well, too. It's a fascinating area of research. It's an important area of research, and I think it's one we're just belatedly coming to understand how important that is.
I had a question. I'm the mom of a 22-month-old who had a stroke in April from the chicken pox. Since then, she's been diagnosed with dystonia. I was just curious if you've had any experience with movement disorders and recovery in kids or adults.
So not so much in children, and this mostly just because most of my clinical work is in adults, but we do know pediatric stroke specialists who've had exactly that experience, and we do see it in adults as well too. So after someone has had a stroke, there's lots of complications that can come with movement, the most common of which is spasticity, where you've got increased tone and stiffness and sometimes pain as well. But people can have other sorts of movement disorders as well. So people can develop dystonia, so that painful posturing. Tremors can develop afterwards. Sometimes people can get a condition that looks very much and behaves very similar to even Parkinson's disease or things such as that. This is an area as well where research is just starting to come into its own in terms of what we can clinically do about that and trying to correlate it to some of the models we see. We can map it to particular areas of the brain that have been damaged. We know in adults that dystonia after stroke is oftentimes treated in much the same fashion in terms of as dystonia that comes for other reasons through the use of medications, even things such as Botox as well. We're still not 100% sure what all the differences are and what the outcomes tend to be, but it is something that we do have experience seeing.
Okay, so I think we have time for one more question, and then we can move it out into the lobby. Right here? Oh, over here? Okay.
Why you said that it's more difficult to detect stroke on children? They don't have the same sign and symptom?
Sometimes they do and sometimes they don't. A lot of it tends to be our expectations about it. So because we don't expect kids to have strokes, we think about different things that could potentially cause it. So for instance, in children, it's much more common for kids to have seizures than strokes. And somebody who has a seizure that's unwitnessed after the seizure is over can have absence of movement that can look very much like a stroke. And in fact, that's one of the more common mimics that we can see. And it's just human nature. You expect to see the things that are more common. And so somebody who is dealing with a group that traditionally hasn't been thought of having that same risk may not think of a stroke at that point. And one of the things we're trying to do in education is to help people understand that that is a possibility, in fact.
All right, so if you have more questions, we'll have the speakers out in the lobby and join us for refreshments. We'll also have posters from some of the students doing the research in the labs and the clinic, so lots of time for more questions. So I'd like to thank the speakers for a great session. It was great. I'd also like to thank the management team for, actually organizing this whole session. So Natasha Hollywood, thank you very much. Victoria Rasher, who's up there, and also Candice Fortier. So if you'd like more information on the brain and mind, or if you want to be on our mailing list, or you'd like to support research at the brain and mind, come and see us at the table. Natasha will be there. And of course, come and join us out in the atrium for refreshments. We have coffee and dessert, and if you have more questions, the speakers will be out there. So thank you so much for being here tonight.